Hi. We all were shocked by this incident. After a month of this incident, these lines were shared in a WhatsApp group. That incident tells us that life is so uncertain, and this is the truth. But these lines are also a bitter truth. This platform has been used or will be used by our colleagues of other specialties and super specialties to discuss their novel ideas and heroic achievements. But I am a poor general surgery fellow. I will discuss a very simple and straightforward case, but the impact of that case is not so simple. So let's first discuss the case. The topic I choose is gossip is like a boomerang. A 34-year lady presented to her OPD with complaint of pain in lower abdomen for 1 year, which was insidious in onset and gradually progressive, non-radiating to any other site, relief on taking some medications. It was associated with burning sensation of abdomen and burning micturition intermittently. There is no history of vomiting, jaundice, constipation, or fever. There is history of on and off shivering at night. There is history of left ovarian cystectomy 1 year ago and cesarean section 5 years ago. Menstruation was regular. On examination, a 10 cross 10 centimeter lump in lower abdomen. The lump was non-mobile. It was mildly tender and firm to hard in consistency. So, with this case scenario, we cannot reach to a final provisional diagnosis. So, we do imaging, and on the CT scan, we found a large, well-defined encapsulated mixed density mass lesion in lower abdomen, adherent uterus and bilateral ovaries are bulky with adnexal cyst. So this CT scan did not give a clear picture. We were confused whether it is a mass or a abscess or what it is. So as per advice of our radiologist friends, we did MRI also, and in MRI, it clearly shows that there is a well-defined encapsulated cystic lesion with wavy structures within the pelvic, averting the posterior uterine myometrium with mild pelvic ascites, smooth external contour, and no obvious infiltrations. So then we came sure to that this is probably a retained foreign body, probably a surgical morph that was left inside the abdomen during the previous surgeries. By the time patient also was suspecting that something wrong has been happened during the previous surgeries, and naturally they was very angry and in anxiety also. So we all our faculties sit together with this patient and her husband. We ask the husband what is your profession, and he tells that he is an electrician by professions. So we disclose the thing that we are suspecting that some foreign body has been left inside the abdomen during the previous surgery, and that needs to be removed by second surgery. And hearing this, that husband was naturally angry and shouted. Then we show these pictures and tells the story, as you are also an electrician, and many a times we heard that electrician died while working in the high tension tar. So was that electrician at fault? Was that electrician negligent or careless to sacrifice his life? Then the husband thinks and says, no, this is an accident. So we tell them that was also an accident. No surgeons or no doctor wants harm to patients, and it is purely a accident. And we give them hope that if we do the second surgery, the patients probably might be all right. So they keep faith on us and give their consent, and we did the surgery, and this is the intra finding. In the abdomen there was a cavity, and within the cavity the mob forms an contained abscess with copious amount of pus. So we remove the whole mob from the abdomen, and whole the pus was sucked, and it was cavity was thoroughly washed with normal saline, so that there is no spread of this infection in the abdomen. So you can see the whole mob has been removed from this abdomen. So patient was discharged on fifth post-operative day. Recovery was uneventful. After 2 months, the patient and her husband came happily. There was no problems, and they were happy. By this operation, we saved two things. One is patient's lives, and the patient's and the previous operating surgeon's career. And they were so convinced by our behavior or our attitude that they did not lodge any complaint against the previous surgeons till then. So this is the happy ending, but this is not the end of my today's session. So let's have some introspections of this whole story. So this is a clear-cut case of Gossypiboma. The term Gossypiboma consists of two terminology, that is Gossypium and Boma. The term Gossypium is a Latin word and it means cotton, and Boma is a Swahili word that means place of concealment. And interestingly, there is no gossip in the word Gossypiboma, but we do gossip about it. Sir Philip Sidney, an English poet, has told that whoever gossips to you will gossip about you. This reminds us that what happens today with others may happen to us any day. And that is why I choose the topic gossip is like a boomerang. And it is not only the mop or the surgical sponge that is left inside the body cavity. It can be a small needle, and it can be a big instruments like a scissor that has been shown in the X-ray. And abdominal cavity is not the only place. Even in the pericardial cavity or the pleural cavity, foreign body can be left. And presentations of patients may vary. Not all patients present like this. Most commonly, the patient presents with abdominal mass or pain, but many patients, it is incidentally detected during radiographic examination or during unrelated surgical procedures. It may be an incidental finding on routine post-operative radiograph. Sponge initially placed in chest or abdomen can erode through the skin or into the GI tract, creating a fistula or intestinal obstruction. The interval between the probable causative operations and the diagnosis of the retained gauge may range from 11 days to 28 years or even more. So delayed presentation, I will explain my next slide why there is some delayed presentations. And it has been also reported that the sponge may be expelled with the stool also. So how body reacts with these cottons? So surgical sponges are nothing but made of cotton, and inert material that does not stimulate any specific biochemical reaction except adhesions and granuloma formations. So body reacts majorly in two ways. First, and the most common, is exudative, that is an acute inflammatory reaction, just like this case with formation of an abscess. This usually occurs in the early postoperative period and may involve secondary bacterial contaminations. But on the other hand, There may be an aseptic fibrinous response, resulting in tissue adhesions and encapsulations and eventually foreign body granuloma formation like these pictures. And these types of patients presents late or may be detected incidentally. So as you know that these types of incident are defined as never event incident as per the WHO patient safety incident criteria. As per the WHO patient safety incident, we divide these adverse event in near miss, harmful incident or no harm incident. Harmful incident may be adverse event or adverse reactions. But is this really a never event? We frequently see these types of news, and this is a latest news. And actually, these are the tip of the icebergs because the actual incidence is difficult to determine because most of the cases are unreported. The retained surgical sponge is reported to occur once in every 3,000 to 5,000 abdominal operations and most frequently discovered in the abdomen, and Gossypibomas make up to 80% of cases. As per the WHO estimate that even in advanced setting, 1 in 10 patients receiving healthcare will suffer preventable harm. Here the preventable harm does not only include these types of incident, but it also includes any sorts of preventable harm like wrong diagnosis, mis application of drugs, wrong doses, wrong drugs. So any sorts of preventable harms. And iatrogenic patient harm being the 15th leading cause of global disease burden. So let's concentrate on our topics. So Gossypibomas or retained surgical foreign bodies is a nightmare for a surgeon because it causes negative publicity of the surgeons and res ipsa loquitur means it is a telltale sign. There is no way to defend himself of the surgeons. There is possibility of suspension of NMC registrations, which surgeons may be convicted under the IPC 304, and there is imprisonment. There may be imprisonment up to 2 years or more. Everybody blames the surgeons. Why you have done this? And surgeons becomes the second victim. Just like any incident, there is always behind a scene, and this has been explained by more than one cause theory. Then who are actually responsible? We need to do the root cause analysis. Human, yes, obviously human is responsible. System, that is the whole hospital system, including the administration and the OT environment. So all these three factors leads to happens these types of incidents. So let's quickly see the individual factors. We all know that human can causes error, and human factors include deficiency in training, inadequate knowledge, and more commonly the overwork and the fatigue, lack of experience, personal psychological factors, and the interpersonal relationship among the OT team. System failure is also very important, like inadequate staff. That leads to overwork of the staff and leads to fatigue of the staff. Lack of infrastructure, like inadequate OT light, equipment failure, cost-cutting measures, like use of non-radiopaque gauge or mop. OT environment. Unplanned change in surgery. Many a times we are doing a laparoscopic surgery and may need to convert to open surgery because some complications. And during open surgery, we take a new sets of gauze or mops. So that may lead to a problem in counting of the gauze and mops. Excessive bleeding during long duration of surgery. So this needs more numbers of gauze. Distraction in OT by some incident happens outside the OT, unnecessary trafficking in the OT, or high BMI patients. So how can we reduce these types of incidents? Sir Herbert William Henry, also known as the father of safety, for his pioneering work in industrial accident prevention. He shows that for one serious injury or death, there are 30 minor injuries, and behind these there are 300 near miss, and underlying these there are 3000 unsafe acts, behaviors, or condition. So we can practice a safe act if we can reduce the unsafe act or unsafe behaviors, or we can improve the working conditions, then that will naturally reduce the number of serious injuries. The other theory, Swiss cheese theory by James T. Reasons, shows that if we can increase the level of scrutinizations, that will prevent the near miss to reach up to the patients. Just for example, a junior resident has done some mistake, and that has been checked by senior resident, or a senior resident has done some mistake or overlook that can be checked by consultant. So by this way, we can reduce the near misses to reach up to the patients. So can we really stop this incident? As we all know that WHO has introduced the surgical safety checklist in 2009. There is no question that checklists are tools that improve the outcome, and but provided they are correctly implemented. The use of the surgical checklist has definitely reduced the number of near miss or the iatrogenic incidents also. But for successful implementation, following factors need to be addressed. There is positive attitude of the staff to use the surgical safety checklist, extensive discussion, education, and training of the staff, ongoing feedback, and local adaptations of the surgical safety checklist. Surgical sponge counting has become a tradition in our day-to-day life, and sponges are counted by hand before and after surgeries. This method was codified into recommended guidelines in 1970 by the Association of Perioperative Registered Nurse. Other guidelines have been promoted by American College of Surgeons and the Joint Commission for Prevention of Retained Surgical Instruments. Ideal timing of sponge counting should be 6. So initial count before the procedure starts, when there is any new items are added, or when there is any change in the scrub persons or circulator, before closure of a body cavity, when wound closure begins, and finally at the skin closure. The anesthesia care provider should obtain situational awareness and engage in safe practice. Anesthesia care provider should not use counted items. If they use any gauge, so they can keep a separate count. But the real problem arises when, after finishing a tiring OT of long hours, the nursing officer tells us that sir, one gauge is missing. Then the mental state of the surgeon is like this: why I became a surgeon? Let's watch this movie clips. I hope you all have seen this.
हम तुम्हें ही ढूंढता था। तुम लोग मुझे ढूंढ रहे हो और मैं तुम्हारा यहाँ इंतजार कर रहा हूँ। ये बात है।
So when we are searching for the missing gauge, if the missing gauge or the missing mobs tells us that मैं यहाँ इंतजार कर रहा है तो कितना अच्छा होता. So is there any way? Yes, there are few recent technologies that can help us to reduce these types of incidents. One is barcode technology. Just like in shop, the shopkeeper use the barcode to easily match the items. So each sponge or towel has its own individual barcode, and each pack has a unique master tag barcode containing data for all sponges within. A trigger an audible and visual recognition cue each item when it is scanned, and it has been clinically proven to help eliminate retained surgical sponge in the largest non-sponsored study published to date on retained foreign objects. Use of universally trusted barcode technology, which also supports compliance with FDA's UDI mandate. Another technology, commonly known as the smart sponge, that uses the RFID technology, that is the radio frequency identification technology, and that is nothing but the RFID tag on our scar that is applied to the surgical sponge. A small handheld device can perform an automated count of inventorized sponge before, during, and after the operations, minimizing the human error in surgical tool counts, allowing for immediate discovery and retrieval of the surgical sponge within the peritoneum, or even the sponge or gauze may hide inside the surgical dressing or draping, or it may be in the uh, fall under the OT table also. So it can be easily detected with the help of this RFID technology. An RFID sponge system would reduce the Gossypiboma. So let's see the video.
You can remove the HUV-read from its cradle and wave it over the closed surgical packs. The back of the HUV-read will show the total number of sponges counted in. The panel PC will show a detailed list of the different types of sponges and.
So you can see this RFID technology not only gives the total count, but it also gives the individual counts of each types of gauze, small gauze or large mops. It gives individualized counts also. So this can help us to reduce the incidence of Gossypiboma. This can help in the hour of crisis. So take home message. So preventing a retained surgical sponge is far more important than cure. Multidisciplinary approach may help to avoid retained foreign objects. New technologies may help to reduce the incidence of retained foreign objects. There should be high index of suspicions of retained surgical sponge in patients with past history of surgery. So at the end, we pray, hope, and wish that this never event should never happen in this campus. Thank you, and this is the references.